Moving on to chapter 34, which basically covers the lower GI tract, specifically diarrhea and constipation. So we'll be talking about treatments for diarrhea as well as the opposite, treatments for constipation. Page 569 in your book covers bowel function. Just review that process. Should be familiar to you from A&P, or if you haven't taken it, it's a good little review under bowel function there. So antidiarrheals, we are looking to stop the movement through the GI tract as fast as it is going and get it back to normal function. The reason we worry about diarrhea is because it can dehydrate people and cause electrolyte imbalances, which can lead to further complications. Whenever somebody has diarrhea, they're getting rid of a lot of water all at once. They're getting rid of a lot of nutrients without absorbing them. So we just want to stop that process and get them back to normal function. So the first thing they talk about are causes of diarrhea, and it can be many different things. It can be emotional stress, poor eating habits. It can be an infection in the gut. It can be from drugs that you might have taken. It can be from, say, if you were traveling and you drank water that had bacteria in it that caused you to have diarrhea. There's a lot of different causes. So the first thing we want to do when we are treating diarrhea is to identify the cause, because we're not going to always want to stop it if it is, say, due to an infection. We want to let the infection run its course. If we stop that diarrhea, we are essentially leaving the bacteria, the bad bacteria in the gut, which can lead, again, to further complications. So, for example, in that case, on the chart on page 570, Table 34.1, the top talks about acute GI infections, viruses, and protozoa. And as you can see, those are always treated with antiviral therapy, antibiotics, and that is to cure the infection, which will then stop the diarrhea. Once those bad bacteria are out of the gut, we've taken care of the problem, so no need for any antidiarrheal agents. So other agents that increase intestinal motility under that, drugs such as antacids, antiarrhythmics, antibiotics, chemotherapy medications. If it's severe enough to where it is causing electrolyte disturbances in the patient or dehydration, we would reduce or discontinue drug use. However, it's something they can tolerate, say 1 or 2 episodes a day. We want to finish up that course of antibiotic or the medication without treating them for diarrhea. Diarrhea is defined, I skipped over this part, but diarrhea is defined, acute diarrhea is the production of loose stools in an otherwise healthy individual that lasts less than 14 days. Chronic is greater than 30 days and is accompanied by weight loss, muscle weakness, and electrolyte imbalance. Okay, so going back to our chart there, C, bile salts malabsorption. If somebody had a problem absorbing bile salts, it would cause diarrhea. The way we're going to treat that, it was with a medication called cholestyramine. As you can see, down below is when we get into our antidiarrheal drugs, such as loperamide. Anytime somebody has chronic gastroenteritis resulting from anemia, cancer, diabetes, neuropathies, etc., that's when we're going to use our antidiarrheal drugs, as well as in situations where somebody is, say, under emotional stress or poor eating habits. So, treatment of simple diarrhea. Simple diarrhea is most frequently associated with poor dietary habits and emotional stress. Underlying causes of increased intestinal motility may be difficult or impossible to determine. Therefore, treatment is usually symptomatic rather than curative. Drugs used include adsorbents, anticholinergics, and opioid derivatives. And they either decrease intestinal motility or they remove the intestinal irritant. And that's what we're going to talk about first. Adsorbents remove intestinal irritants. They bind whatever is bothering somebody within the intestinal tract, and they get it out of there so it can't cause any further problems. Drugs in this class include kaopectate, which is kaolin with pectin, adapulgite, which I always have trouble saying, diasorb or Kapec, and bismuth salts, which most of you are probably pretty familiar with. That's that nasty pink liquid that actually doesn't taste awful, but it's kind of gross to swallow because it's really thick. And what that does is it'll bind things up within the stomach and the intestine, and it'll sort of coat it to prevent anything else from irritating it. Then they're flushed out in the feces, problem solved, no more diarrhea. So adsorbents are not usually administered with meals or other medications because they can prevent the absorption of food and medication. So we separate that by about 2 to 3 hours on either side, before or after. They're usually dosed per each loose bowel movement. So anytime somebody has an episode, they would take a dose of these medications. and they're given up to 6 to 8 times a day, depending on the product. Traveler's diarrhea is something I mentioned before, which is where somebody would come into contact with a bacteria in the water in a foreign country, and that can be treated with Pepto-Bismol preventatively, so somebody could take it when they go to the country to prevent traveler's diarrhea. And again, that's just going to line the stomach and prevent the irritant from ever coming into contact with the GI tract. It can also be treated with another medication, a newer medication called rifaximin. Rifaximin prevents bacteria from growing in the intestinal tract and is taken 200 milligrams 3 times a day for 3 days. It's not used to treat necessarily an infection, but used more as a preventative in this case. So anti-motility drugs, these are the drugs that are going to stop the GI tract from having peristalsis, which is covered in the first page of this chapter. So anti-motility is exactly what it sounds like. It stops the mobility of the GI tract. These medications interact with specific receptors such as cholinergic, serotonergic, or opioid receptors, and they inhibit the postganglionic receptors of parasympathetic nerves that control intestinal motility. It's kind of a complicated system. There's no, I mentioned a lot of big words there. There's no questions on your test that will be covering those specific nerves or receptors. What you need to know is if it says anti-motility, it's exactly what it sounds like, that it is slowing down the motility of the GI tract to allow food to stick around for longer, water to get reabsorbed, and stool to be normal, not loose and watery. So don't get overwhelmed by that huge picture on page 572. Go over it, look at it, try to understand it, but don't feel like you have to commit it to memory or memorize that it inhibits the postganglionic receptors. It's not going to be what's really important here. So medications in this class, the book mostly covers difenoxin and difenoxylate, which actually when you give the body difenoxin, let me see if I have this right, because difenoxin isn't used that often. More often than not, you see difenoxylate with atropine. That's the medication that's used pretty commonly for diarrhea. They're both related to meperidine, and difenoxin is more potent. So what happens when the body takes in difenoxylate is it turns it right into difenoxin. Okay, so we more often than not give difenoxylate with atropine. I don't think I've ever seen difenoxin given in the pharmacy. I've never dispensed it, never seen it on a shelf, so don't worry too much about that one. The brand name for difenoxylate with atropine is Lomotil. Atropine is an anticholinergic, so that's going to slow everything down, prevent diarrhea, and actually usually a side effect of atropine or anticholinergic drugs is constipation. So that's one part of the medication. Difenoxylate is a mu receptor agonist that stimulates mu receptors in the myenteric plexus to decrease peristalsis, which is, again, the squeezing of the GI tract that allows the contents to move through. So if we slow peristalsis, we're leaving things in the GI tract for longer. They're going to sit there for longer before they get pushed along. So loperamide is our other medication that is used most commonly to treat diarrhea. It's available over the counter, and it is given at 4 milligrams per loose bowel movement, not to exceed 4 tablets per day, so no more than 16 milligrams per day. It can be used in IBS when the person who has IBS has diarrhea as one of the symptoms. However, usually what they'll do is they'll find a better medication because, again, there is a limit to this medication, and it doesn't, sometimes your body grows tolerant to it, and it can cause constipation as a side effect. So loperamide has often been used in combination with a trimethoprim and sulfamethoxazole for traveler's diarrhea. So as you can see, there's a couple different treatments for traveler's diarrhea. So cautions and contraindications of antidiarrheal medications as a whole. They're relatively non-toxic because they're not usually absorbed into general circulation. However, the most common side effect to many of these medications is constipation. If you're treating diarrhea, you stop that diarrhea, now the patient has constipation. So it's kind of a fine balance, which is why we don't want to overdo it with antidiarrheals. Difenoxylate is absorbed, so it would cause rashes, dizziness, blurred vision, and nausea. Over-the-counter preparation should not be used by patients who have glaucoma. That is one of the side effects of a lot of anticholinergic drugs because they increase intraocular pressure by reducing interior chamber drainage in patients with glaucoma. So hopefully those patients who are coming to pick up over-the-counters are talking to their pharmacist or whoever they could be in contact with as far as a medical professional. Always remember, any anticholinergic drug, not good for patients with glaucoma. Okay. Laxatives and cathartics, moving on to those. The book does cover elocitron, going back to diarrhea, the book does cover elocitron, and it's just not dispensed that often. It's got a big black box warning on it. It had a lot of problems. It was pulled from the market, and now it's only used in last sort of ditch effort situations. So it's not really available to the general public, so I don't want you to worry too much about that medication. You're primarily focusing on Lomotil, loperamide, and the traveler's diarrhea medications. Moving on to laxatives and cathartics. Now we have patients with constipation, and we want to get their system moving again, kind of flush them out in some cases if they're going for a GI prep. So laxatives and cathartics are pharmacological agents that stimulate defecation. Laxatives are a little more gentle. Cathartics are exactly what they sound like. It's a very intense bowel movement that happens really quickly. So they act directly on the intestine to alter stool formation, and there are only a few valid indications for the use of laxatives. Somebody who has chronic constipation, somebody who's going for a GI prep. If we're trying to, I would say GI prep would probably be the most common use. People do use laxatives a lot, however, they're not supposed to be used long term or frequently because it changes the way the body responds to its own signals. So constipation is defined differently by patients as well as healthcare professionals. Some people think that if they don't go once a day, they're constipated. However, constipation is really less than 3 bowel movements per week. That's the common definition. Chronic constipation occurs when symptoms last more than 3 months. So things that can contribute to constipation: poorly developed toilet habits, diet low in fiber, certain drugs can cause constipation, certain diseases can cause constipation, anxiety, fear, and other emotional disturbances. Laxatives are employed to facilitate defecation without straining, stress, or pain. If we're putting a lot of strain on ourselves when we're trying to go to the bathroom, we can actually cause damage to hemorrhoids or hernias, or if somebody has a cardiac history, it can be harmful as well. So laxatives are classified based on their mechanism of action. In this case, we have osmotic agents, swelling agents, emollients, chloride channel activators, and mu-opioid receptor antagonists. Stimulant laxatives act directly on the mucosal lining of the intestine. We're going to cover swelling agents first, and actually I'm going to switch to a different video because we have a cutoff of 15 minutes.